Good morning, everyone. It's wonderful to be here all the way over here in Brisbane, Australia, being able to contribute to the think tank. Hopefully one day we'll be able to have a live discussion. So it's been suggested that I talk about our research and work on family-centred hearing cares, as that might contribute to some of the thoughts you have in the tank. So, first of all, what is family-centred care? It is an extension of person-centred care, which concepts I'm sure you're familiar with. And just to define that, family is not just biological family. It refers to two or more persons related in any way through a continuing biological, legal or emotional relationship. And I'm sure you can all think of people in your lives who are not biologically related, but you would consider as family. So these are key people in your life. And our argument is that they're key people in the lives of older adults. And I'll talk to you about why that's so important in hearing care. So the big picture of our research is that we've been exploring the relationships between being well, and well-being is a hot topic for older adults, hearing well, and family. And we've been thinking about the audiologist's role in helping clients and families to hear well and to be well. And this is where family-centred care comes in. So you can see the sort of big picture there with being well, the large blue wheel turning around, which is prominent in people's minds. And also family is related to that. An area that gets much less traction is, of course, the importance of people hearing well, to be able to be well and to be able to engage with family. So when we've been thinking about being well, we started looking at the work of our psychology colleagues here at the University of Queensland. Kath Haslam's written a book, I think this might be the second or third edition, of the New Psychology of Health, Unlocking the Social Cure. And in that book, they're really pointing out the importance of connection in people's lives. And of course, that's all been highlighted through COVID at the moment. And what their research shows is that social ties are at least as good for your health as not smoking, having a good diet, taking regular exercise, the things that people most often think of. So this New Psychology of Health moves the field of psychology from considering the individual, I and me, to people's psychology as group members, so social identity theory. So we've been working with that team and exploring this idea. And you can see there on the cover of the book, they have pills that relate to social connection, like book club. And a very prominent one there is family, because family is the most common social group that people belong to, and very important for older adults in particular. And this is just to highlight the importance of social ties again. So on this graph, what you can see in the green is a meta-analysis of the true rankings of the importance of behavioural risk and social factors for mortality. And number 1 and 2 are social support and social integration. And things like not being obese, medication, etc., according to the data, are less important for mortality. But when you ask people, and what they did in this study was they did ask, surveyed hundreds of people about what they thought was most important for mortality, and they're the red dots. And what you can see there is that people tend to believe that social support and social integration are less important for quality of life than not smoking, for example. So I suppose it's something for us all to remember. If this survey shows that's people's beliefs, that they don't give social support and social integration enough of a priority, if you like, in terms of people's well-being and quality of life. So what we noticed in this literature is that in psychology, they're talking a lot about people getting older, being well, and the importance of family. Okay, that link is clearly there. But what's less brought together is the idea that hearing well plays a role in this. And we'll talk more about families' roles in hearing well. But it means that these ideas go together, if you like. So hearing well is important to maintaining group membership, relationships with families, and that is critical to quality of life as you age. So this is some of the evidence that we've gathered over the last 8 or 9 years, I suppose, about hearing well in families. And I'm happy to share any of these references if you want to look at the detail. But just to say that we know from the research evidence that people with hearing impairment are more likely to seek help if families support them. And this research has all been done with older adults. So the family play a critical role in people's just taking some action about hearing well. Okay, so they have a vital role to play. Not surprising, hearing loss is a communication impairment. So it doesn't just affect a person with the impairment, it affects those around them. Families help with rehabilitation decisions. So when someone goes to see a professional about their hearing and they have choices, they can do something or nothing. They could get a hearing aid, a cochlear implant, an assistive device. They could consider communication strategies, but they have decisions to make. And they all report, those older adults, that families are key to helping them with those decisions. We also know that if then decisions are made around technology, and the most common technology there would be hearing aids, if the families are supportive, and they're not always supportive, people with hearing impairment are more successful hearing aid users. So it's important at every step of the way, if you like. And then the fourth point there relates to the impact of hearing impairment on the other, on the family. So if families participate in hearing rehabilitation, this can reduce the disability that they experience, because as I said before, hearing loss is a communication disorder. So it affects others as well, and that is referred to by the World Health Organization as third-party disability. An example would be an older couple where they no longer go out, neither of them, because of one of them having a hearing impairment, which means they don't enjoy going out to social events. So both have a disability. So we know that it can help families to engage in hearing rehabilitation because they also experience these issues. And finally, we know from another big data set investigation, not by our group, but by colleagues, Gurjit Singh and Stefan Launer, that when family members attend appointments where hearing aids are discussed, adults with the hearing impairment are more likely to obtain hearing aids. So they have a key role to play. So we would argue that practicing family-centred care will help adults with hearing impairment to hear well, be well, and that's facilitated by successful group connections. Of course, also helps the other. It also helps the family members. And most recently, we've produced this book, which has an ebook version, but it's focusing on patient and family-centred speech-language pathology and audiology. I would say that my speech pathology colleagues are more advanced in this space than us. For example, they consider the client in speech pathology, communication disorders services in Australia to be the whole family unit. Whereas in audiology, we still focus on the individual with the impairment, with much less emphasis on the patient being the family unit. So what family-centred care happens in audiological practice? Because whenever we talk about this at workshops and conferences, etc., people are very positive. Yes, family are important, but how are they involved? We know they're important. We can't just assume they're going to be involved when the client goes home from the clinic. So we looked at how often family members attend appointments, and that is between 20 and 30% of the time in a range of public and private practices in Australia. When they do attend, the family members are not typically invited to join the conversation during the clinical interaction. So they're there, but they're more observers. So what some family members do then is that they self-select to speak, meaning they interrupt, if you like. So the audiologist will ask a question to the person with hearing impairment and a family member will respond on their behalf. If they're not invited in, they'll self-initiate expansion. So the person with the hearing impairment might say, oh, I don't have much trouble listening to TV. And then the family member is saying, oh, yes, you do. It's much louder than I would like it. So I'm sure you can imagine these interactions. They're quite common, and it's what we observe in clinic. And they also, family members also self-initiate their own questions. You know, what causes this hearing loss? Why can't he hear me sometimes and not others? But what happens when they do self-select and try and join in? The audiologists are very quick. The ones that we observed in our research are now some over 150 clinical interactions. The audiologists typically responded by shifting the conversation back to the person with hearing impairment. So much less attention to the needs and the perceptions of the family. So then we started to work on, well, how can audiologists practice family-centred care? And for that, we've been using largely the behaviour change wheel approach, looking systematically at barriers and facilitators to implementing family-centred care, and then interventions that might improve that. So we've taken a whole of clinic approach because that's what's needed. You've actually got to get the family member attending the clinic. People talked a lot about, oh, we can ring them later and we can, you know, engage them on Skype, etc. But they didn't do it. It's not what we saw. So they relied very much on the face-to-face clinical encounter. And if the family weren't there, they didn't get the family perspective. So this whole of clinic approach, we work with all staff in a number of clinics to think about the physical setup that they have. And by that I mean including a chair for families. Look, in some clinics that just wasn't there. And if a chair or chairs were there, they were pushed back and not bringing all the participants in the appointment together. So it tended to be that the family member would sit away or behind the clinician and the client. So we talked to them all about ensuring physical setup and welcoming of families. And that happens from the moment you come in the front door of a clinic and then, of course, into the clinic room. We work with front of house staff to increase family member attendance at the clinic because they make the appointments. They need to invite people, family, to attend in any written correspondence, in any phone conversations. They need to explain why family should come along and why it's important and how welcomed and important they will be when they do come. And then we worked with clinicians to increase engagement with family during the appointment so that the family get a chance to speak, that they don't have to self-initiate everything that happens, that they are invited to join. So just to say a little bit about our results so far. With this work, we have been able to, in the clinics we've been working with, increase the percentage of family attending appointments. We have some clinicians, it's variable, some clinicians engaging more with families. We have very positive feedback from patients and family and some insightful comments about how they participate. And finally, just to mention that implementing family-centred care sounds simple, but it's not simple. It's got some real challenges in the real world. So in a number of clinics that we've been working with at our first follow-up, so we're doing this intervention in 2 phases. After the first couple of months, there was an increase from 30% at baseline to 46% of appointments with family members attending the clinic. And we're still following this up. It's work ongoing. We then looked at the behaviours in the actual appointments between the family members, how were family engaged with the clinicians. So we developed a 20-point checklist, and that's just some examples of the checklist here. I know this is just a brief overview. So because there was no measure for us to evaluate family-centred care in these clinical environments, we're using this checklist. We're also using conversation analysis to see how family participate. So we've got, you know, point number 1, do family members, are they present in the room? Down to number 20, more detailed engagement. Clinician discusses expectations, future actions of both patient and family. So if you're completely family-centred, you would get 20 points. So we just rated them as 1 or 0. And just to show you what we found with a range of clinicians. So a lot of them are starting off at quite a low base with only 1 or, you know, average of 1 of these behaviours. Some start at a higher level. So one person there having 12 of these behaviours exhibited already, the red line at the top. But generally what we did see pre and post intervention was an improvement. So some clinicians are engaging more with families following these interventions, which were workshops and individualised coaching for clinicians. So what did families say? Their involvement viewed very positively, and you can see the quotes there. I'll just let you read that for a second. I don't need to read it out. So the first two talking about something being good, probably good, beneficial. So PHI is person with hearing impairment, and FM is family members. And the second set of quotes, they do use language that indicate that they could see that the family member contributions at times may be unwelcome, and that limited what they might say. So you can read those as well. So these are complex interactions and complex experiences for family. I know if you yourself have ever been in an appointment with a family member where you're wanting to help but not wanting to go too far, I think you can understand the tension that they describe. So just to say this about the implementation research is very challenging, and we found this very challenging. So training staff is a continuous process. There's turnover of staff. It will take some time to embed behaviours into routine clinical practice. We feel that workshops, conference presentations, webinars, etc. are not enough. You need coaching. You need coaching in the clinic, because there are different reasons why all of the staff did and didn't do sort of various things. And finally, just to comment that attendance in the scenarios we looked at was the start of FCC. It doesn't mean that family-centred care is occurring, but it's the beginning. I think there's a whole new realm of work we can now do about family involvement now that we're using a lot of telehealth appointments. How are family involved? There's enormous potential for them to be more involved in that scenario. But is it happening, and how is it happening? So that's where we're headed at the moment. I hope that's given you some ideas about family-centred care, and I look forward to contributing in whatever way I can. I'd like to thank our various funders, including Sonova, whom I've missed off that slide. My sincere apologies, Sonova. They have also supported our family-centred care research, as well as the Oticon Foundation and the IDA Institute. So thank you all very much, and I hope you have a wonderful collaboration. I look forward to joining you when I can.